Registry has been a part of our medical home and really achieving what that sets out to do. I included a photo of myself and my family here just so you have some sense of who I am. I'm a family doctor in Woodland Park. I've been here since 2004, and my wife Heather is also a family doctor, so we share the practice here, and we're basically in solo practice except there's two of us. So first slide here, we're going to sort of break down this diagram of what a registry is all about, and my vision as well as others is that there's sort of three pieces to the pie that makes up a registry. There's a piece that's about proactive care, as sort of a new posture to care, where we're trying to do things ahead of time and trying to anticipate patient needs. And then the registry is also going to help in the actual delivery of care, so guiding care, which you might term decision support, the tools that sort of help you decide what needs to be done and to do it as efficiently as you can at a patient visit. And finally, there's two aspects at which the registry is going to help improve care, and that's going to work both at a patient engagement and self-management level, where you're working just with the individual patient and trying to improve their health, but also registries will help improve your whole system of care, so how your office functions and how well you deliver care to a population as well. So just to kind of focus in on this first piece of proactive care, oh, excuse me, I have to mute my phone here. Okay, so before the visit, this piece is really thought of as the population management piece. And a registry is going to help identify the care needs for your patient population and then assist in the outreach efforts to meet those needs and do that on an ongoing basis. Then at the visit, what we would also maybe call decision support, this is where a registry is going to help prepare us for planned visits, things like prevention or chronic disease visits. It's going to guide the delivery of services at these visits to ensure that the appropriate and complete array of services are provided and that we do that in as efficient a manner as possible. And then after the visit, we're going to stay engaged with our patients, and the registry is going to help assist in that ongoing work of moving patients and populations towards better health by establishing and maintaining a system for monitoring performance and guiding change. So these three sort of broad areas, all of which the registry is going to help us with. So some thoughts about that first piece of the proactive care. When you're trying to no longer be sort of reactive to patients coming to you with acute problems, or maybe they've got chronic diseases, but the patient's really initiated the visit. Now we're going to look at how we could be more proactive about this. So we need to identify what patient or what population we want to examine. That's really kind of the first step in terms of setting the scope for your work. And then you want to decide how you're going to perform the outreach. So starting kind of with the end in mind, in terms of what's your actual interaction with the patient going to be, whether it's a phone call, it's still going to be visit-based, or you want to use email or mail. So it's good to think about that from the start if you set up a registry, that you're actually enabling it to do that final outreach piece. And then there's also some important things to think about how often you're going to perform the work of evaluating need and doing outreach, because the registry will help you with reporting functionality to get a snapshot, but you'll quickly realize you have to decide what kind of regimen you're going to stick to checking those reports, who's going to do it and how often, and then what they're going to do with them in terms of outreach.
It sounds like there's a little bit of a background noise. If you all could just please look to make sure that your phones are muted, that would be fantastic. So
if we kind of run around the circle one more time here, moving to guiding care, and this being, again, what happens at the visit, some thoughts regarding decision support. So, again, you're going to want to identify, you don't want to just try to implement a registry practice-wide all at once, but I would encourage you to sort of focus in on a specific type of visit that you'd want to employ planned care. Diabetes is very often where there's good standardized, sort of mutually agreed upon guidelines. It makes a lot of sense to start with a condition like that, but there may be others you want to consider. So thinking about how you'll bring the registry into planning for these visits, to what extent the registry is going to help before the actual visit occurs in terms of group huddles, identifying the needs for that day or the services that are going to be rendered. And then how you're going to use the registry to actually guide the visit. Will it be something that you're going to print out and have a flow sheet, for instance, that you'll work off of, or whether you have computers in the exam room and you'll want to use more of an electronic interface. And we'll talk a little bit more about those different options. And then how you're going to use the registry into follow-up. So as you establish needs for the patient, but you're going to make a referral, for instance, for testing or a consultation, how are you going to use the registry to help track that, the result tracking essentially, and how you can move that into the follow-up process and what we term then sort of care management. And then again, how are you going to do all this most efficiently? Again, trying to add this functionality to an existing system can often be very hard when it just seems like another add-on and just more work. But are there ways that you can do that work better? So I'm going to use some screenshots from the registry we use throughout this talk. You'll see some pictures like this. This is called Reach My Doctor on the patient side, and Health Teamworks has branded sort of the physician side of this, which we're looking at here. This is an individual care plan for a diabetic patient. And you can see here that we can set up for specific measures within diabetes care, such as checking blood pressure, checking weight. We'll set intervals for how often we're going to do that. In this case, for blood pressure, be it every visit. I have a little marker you can see here. So the status lights over here will indicate which items are due right now, as I pull this up on a web browser, basically. So I could see things like the retinal screening at this point in time has been taken care of and has a green light. And as a provider, it makes very efficient visits to quickly skip over that and just move to the red items that need attention that day. More of a paper-based solution. This is, again, from the same registry program, but this would be a flow sheet that you could print out. It includes all of the diabetes measures here. Again, this is a diabetes-specific flow sheet. And then there are these grayed out boxes on the right here where you could write in the missing data, but it also gives you some of the historical values to look at. So imagine that this could go on the front of a paper chart, be printed out before the visit, and then as items are collected, they're written in here and then reported into the registry at a later time. In terms of improving care, again, I think I'd mentioned the first two sort of portions of this, patient engagement, again, thinking of improving care for an individual patient. So this involves collecting data so that you can monitor performance, but then also using that as a tool to guide change for the patient, as a motivator for the patient to see their progress and to have some feedback in terms of how they're doing. But a registry is not only going to give you that sort of individual patient report, it will give you population level reports, so you can see what the average A1C is across your diabetic population, or identify people that are out of range. So again, monitoring performance population-wide, and then performing more outreach to guide change in those the targets. Finally, there's going to be a piece of where registry is going to help you in more of a systems improvement level, and that's going to be just how you deliver care and how well you're doing at collecting data, for instance, is going to be one of the first challenges, but how your office workflow, how your team works together, if there's areas internally that you could improve the care that you deliver. So this would be an example of, at the patient level, we have an individual patient's body mass index and A1C values historically here. And how I use this is to pull up this registry when I'm with a diabetic patient and to try to bring them up to date on kind of where they're at. And they can see, for instance, on this A1C graph, how they have, we're in a bad place, and they've really done an excellent job of getting to a better place in terms of their glycemic control. So I think patients really love seeing this. I think they often really appreciate that we care enough to collect data on them. And then when they see numbers like this, well organized, that they can understand and see patterns, it really does help get patients engaged in their care when they realize that we're keeping track of it. If it's something measured, it's something we obviously care about and something that's important. Then if you step back to the population level, you could get reports such as these, where you have for an individual month of October here, for instance, we have all of our diabetes measures, which would correspond to those items on the patient individual care plan. But now we have across the population, in this case, we can see that the A1C was documented in 42 out of our 44 patients, say, that have a care plan. So we can see documentation rate, which we consider like a process measure, as well as outcome measures in terms of how the patient's actually doing. So we can see where their A1Cs are at. And this gives us both the raw numbers as well as the percentages here to see how the practice is performing on this diabetic population. This is a slide that I've found helpful to sort of explain the difference between an electronic health record and a registry. And these lines are definitely becoming blurred by meaningful use, where essentially the electronic health record is having to become more and more of a registry. But the fundamental analogy here is that if you were to think about what an electronic health record was designed to do, really is to record a clinical encounter, basically to collect the story. So it would be sort of a narrative event, and you would, if you were doing this just with your Microsoft Office suite, you would probably pull up a Word document and start writing down the history of the patient. You might throw a little table in there from time to time to track some vital signs, but you wouldn't pull up Microsoft Excel and start recording in little boxes all the parts of an encounter. And this is kind of how EHRs that are user-friendly basically work at gathering this narrative history. Whereas a registry, if you actually wanted to sort of start doing graphs and track performance, you wouldn't reach for Microsoft Word, you would go for Microsoft Excel. And so there's a fundamental difference in terms of why these two products exist out there. And in the medical world, it's kind of the difference between what an EHR does and why it's built the way it is, and what a registry does and why it's built the way it is. So anyway, helpful analogy. But again, I think with meaningful use, essentially what happened was that the requirements were to do more and more quality improvement and population health management. And registries or EHRs were asked to provide more and more reports and graphs and figures and numbers on how you're doing, for instance, with diabetes care. So I think the EMR industry has been sort of stretching itself to try to fit that square peg into the round hole in trying to do registry function. So workflow integration, I think, we started our practice in 2004 with a vision of being a paperless office, and we sort of had to build solutions that would fit around that. But we also learned that it was a lot about the workflow in terms of how you interact with technology and how you interact with each other, and considering new ways of doing things. And so the registry really became an important part of how you think and work differently in the office. And so this portion of the talk here, what I want to talk about is just to start giving you some ideas, or maybe spur some questions or thoughts about where in your office a registry might integrate. And from the start, I would say that it doesn't work very well as an add-on. If you have a practice management system and perhaps you've got an EHR now, and you want to start doing registry, if you've been fortunate enough to have the money to buy a very large EHR system that has great embedded registry function, that's fabulous. We were not in that situation where we were sort of looking at piecing these systems together. And again, what we found was that in order for the registry to actually get used, the office had to be designed around the registry, and it became that integral part of how the work was actually done, instead of just something off to the side that we would sort of tend to when we had spare time on our hands. So this is going to be kind of the who, what, where, when, and why of registries. What is it that is registry-related information? And if you divide this between sort of the barrier of the front office and the back office, in the front office realm, it pretty much comes down to just those patient identifiers, perhaps a chart number or unique identifier provided by an electronic health record or practice management system, and then the patient demographics, all that important information for accurate outreach is going to be something that's going to be collected generally by the front office. And then on the back office, you're going to get more into the clinical stuff. So guideline-based measures such as smoking status or depression screenings. It could be clinical data, just raw numbers like blood pressures and weights, or perhaps medication or immunization. It's going to be procedures and services, so things that are maybe done in your facility, maybe not. For For instance, we refer out for colonoscopies and retinal exams, so this is something that is information coming to us externally, not something performed internally. Diabetic foot exam, though, would be a sort of service that's provided with part of the physical exam, and how do you capture that information for a registry? And then think about laboratory data, again, might be coming from internal or external sources, but things like A1Cs and lipid panels. And then even stretch your thinking to consider, patient blood pressure readings or glucose logs, things that patients collect, and that may be relevant to their care and something you want a registry to be able to track. So who's going to handle the registry information? In the front office, again, pretty much everyone in the office you can think about, whether it's the front or the back, someone at some point is going to touch something related to those pieces we talked about on the previous slide. Where is the registry data? I guess not so much that it matters, except that you need to standardize the location of it so that everybody's looking in the same place and putting it in the same place. If you're using, trying to gather information out of an electronic health record, and it's going to be something more text-driven, such as physical exam finding, using templates that can later be searched so that you report it the same way every time, and you have a way of sort of pulling that data out. Maybe something you need to look at in your office, just getting everyone on the same page and how they document things. And then using tables that can be queried for discrete results. Again, that is essentially most electronic health records have tables of data, and so if you all put it in the same place, you can pull it out easier. And sometimes this does become a parallel process where hopefully less and less of this moving in the future, but where people create standalone spreadsheets where they're just going to dump those A1C values or blood pressures. Again, as that becomes a lot of duplicate data entry, it's kind of onerous and prohibitive to successfully use the registry. So I think integration is a great thing to work towards. The when and how of registry-related information, how it's handled. Again, the front office, if it's patient-collected data, well, patient check-in certainly is an opportunity for getting that demographic information, but it could be coming from telephone conversations where a patient calls in and says, I had my colonoscopy last week or got my flu shot on October 1st. Can you put that in my records? Maybe things coming in the mail, such as reports from other consultants, or maybe you're getting faxed results, or even patient email. More and more, we're using electronic communication and having to gather that data. On the back office side, it may be the loading of patients, recording of vital signs, for instance. It may be things that occurred during the appointment, or it may be something where the patient's not at the office, but you're reviewing results from lab work that was done last week. When the provider is reviewing that result, so they have an opportunity to make that registry data. And then certainly in terms of the outreach work, you're going to have your head pretty deep into your reports and your patient outreach lists. In what format is the information received or kept? Again, the point here is it could be a variety of sources, and you really, as sort of a quote paperless office, what we've found is there really is no such thing. It's more of just having a flexible system that can sort of speak both electronic and non-electronic languages. So you have a way of turning mail and fax and little scraps of paper that patients bring in into something that can interact with your electronic system. Or do you have a way of capturing verbal data from patient phone calls or call reports from facilities and not miss the opportunity to put that important information into your registry? And then electronically, again, some of these may be integrated where it's your EHR data, for instance, is nice and electronic and you can query that, but it may be other ways that it's received through fax, email, patient portals, certainly. Often it's another integration challenge there. We're sort of required to offer patients this secured option, but it becomes often difficult to get that sort of siloed information back into your registry. And then practice management software, electronic medical records, that data becomes a good source for populating your registry data. So what do you do with the information once you've received it? Well, front office may be as simple as just filing it or routing it to a provider, routing it to a consultant, or getting normal results back to the patient, or with some sort of comment from the provider on a result. So there's a variety of things that are done, and again, the thought here is that how could a registry assist this work of moving stuff around, putting it into an organized system where you can access it quickly. On the back office side, again, there's that review and sign off of documents. I think a registry we found to be a helpful integration point. And then certainly what's done with it in terms of outreach, I think we've already touched on, scheduling follow-up appointments, prescribing a medication, ordering a test, and then again the routing function on the back end between staff or externally to consultants or to patients. So I present here sort of the three options for when the best opportunity is to capture the data for the registry. And if you recall back to those initial examples I showed you of the web-based sort of form, or the print something out, write it down, and enter it later. Option one here would be directly entering it into your registry. So you've got a computer there at the office visit, and you're doing that essential double data entry of recording a blood pressure in your EMR, and then turning around and recording it in your registry. It's all electronic, but it's not the most efficient way of doing things. The second option would be, for those in more of a sort of manual environment, would be write it down somewhere, and then at a later, more convenient time, put it into your registry. And then I think what we've sort of been through all three of these steps, and evolved to, there's probably a fourth step of complete integration that I didn't put in here, where the registry and the EMR are the same. And again, hopefully that's more of what we see in the future. But the third option here was to collect the data in a convenient electronic format, such as in your EHR, as you would normally do in your process of documenting a visit, but then electronically batch upload that data to your registry at a more convenient time. And that's the point that our office is at now, is really sort of collecting this data electronically, querying it, and then doing a batch upload to populate the registry so we can get the reports that we want. This would be the sort of data entry at the point of care. So you would have this web page open, and you would check off, if they're in for a diabetes-focused visit, I'd put the blood pressure numbers in here, record their weight here, remember the last height, so it's going to calculate a BMI for us, and you just work your way on down the list. You have the status indicators here again, so the provider could use this as a decision support tool too, to know that, okay, it looks like I haven't done a lower extremity exam the last year. Let's go ahead and do that, and I'll check this box, and then it's sort of done from the registry standpoint. And then again, you've seen this before, but this would be the spreadsheet option, where you'd print this out, and then you would write in here a check for something that these items had been done today. And then at a later point, office staff, for instance, could go in and do the data entry into the registry. And then this would be an example of the third, which you see here is an Access database that we have, where we've sort of queried our EHR. We've pulled out the important, basically a patient identifier, the date of service, the protocol. So this might be, for instance, that a foot exam was done, and then that the response was yes. This 4-column Excel spreadsheet basically then can be uploaded to the website, and you can turn 3,630 records all at once into your registry, and you get your big, beautiful reports. So it's sort of the one foul swoop approach of a batch upload. So a question here, can capturing the registry data make your office workflows more efficient? And I think this is an important thing to think about in having a successful use of a registry, is you really want to do things better. You just don't want to do more stuff. So what we found is in speeding a routing of results to patients, to providers, to consultants, using the web portal functionality, that there was a lot of messaging that could go on, where you could transmit results securely to all these people and really save yourself some time. Improved organization of data, I think we found that speeding that access to data for everyone within your work environment really becomes a great problem solver. So when a patient calls up and needs to know when the last tetanus shot was, perhaps you could search through your patient chart or your electronic health record, probably even faster, and pull that up. We also found that the registry was a great way, if you have it sort of comprehensively populated with the information, that staff can very quickly know exactly where to go to find the answer to the questions. And so it means that providers have to get involved less in troubleshooting, and that our staff can sort of address patient complaints quicker. Improving documentation of the office workflow in order to have future clarity and improved efficiency. Again, I think there's a lot of work that goes on in an office that really doesn't become always part of the medical record, but is important in terms of, particularly I think around prescription refills and knowing where prescriptions were sent and when and how many. Again, the EHR has done a great job of helping us to have more information in that. But again, once the provider has done something, it's good to have that documentation so that, again, anyone that comes into the system can see exactly what's been done. And again, it helps with that troubleshooting of patient needs, becomes a much more efficient process. This is a schematic of sort of how our office has approached the whole paperless and electronic questions. And what we found was we adopted an EHR from the start. And at about 2007, we started working with the registry. But we also had this sort of horizontal access of how do you move the data from the EHR into the registry, and so we needed something to perform that. And in our office, this document management system at the center essentially was another database that helped pull data from one source and send it to another. And then on the vertical axis, this document management system helped us to make sense of and organize all the paper documents that came into the office and really move those into an electronic format, so that we don't have a chart room. We've just got a big server that has everything on it, but we put it in there in an organized fashion so that we can get to it quickly and know exactly where things should be. So that document management bubble in the middle of the diagram there, this would be a screenshot of the database that we've built and used in our practice to do this kind of result tracking. And this is essentially, as we applied for patient-centered medical home, this was the solution that we certified with in terms of our result tracking, our order tracking system. And so I found this to be very helpful in our office, and it does provide this level of documentation. For instance, in this case, you can see the text of the email that I had sent to this patient congratulating them on their good cholesterol results. If I came over to this track data, what we would have here would be a table where we could input a discrete A1C value, for instance, of 7.3. Once I put it in that table, it would show up both in the electronic health record, but then that would also be where the registry would query for its data, and so that would be a part of that batch upload I showed you before. So this, you can see that the sort of centralized role of this document management system. And again, as you're looking at electronic health records, perhaps looking at purchasing them, an important area of functionality to look at is this document management system and how well you could see your office staff sort of working with all the paper and the stuff that comes through your office, and how you route things, how you organize and name documents, because I think that level of organization will really pay off in terms of office efficiency. So I guess if there's any questions, I'd be happy to take some at this point. If not, I'll move on forward, but let me stop and just see if anybody has any questions so far. Okay, well, hearing none, we'll proceed. So now we get to the sort of now what question that we have integrated our registry with our workflow. We're starting to get some reports, but what do we do with them now? So it sort of becomes what next? So I've got some examples of some data collected from our practice here. And over time, this shows the blood pressure values in our diabetic population. So this top red line here is the count of diabetic patients as our practice grew. You can see the documentation rate in the brown line pretty closely follows the patient size. So that's meaning that we're doing a decent job from the start of recording blood pressure. Not perfect, but we're getting some. And then you see the control, sort of the outcome measure, the blue line there of folks that are under 140/90, the sort of tan line of folks that are under 130 or 80. You know, as a provider, I kind of find these graphs fun, but I don't exactly know what to do with it at a patient individual level. I still find, you know, blood pressure management becomes just about the patient in front of you, and perhaps there's some outreach that could be done to make sure we're getting blood pressures on patients, but it's really about the decisions of what's the best treatment going to be for this patient in front of you. So again, I think this graph demonstrates a decent documentation rate that we've been able to document this clinical measure in our practice, and the results are somewhat sort of theoretically interesting, but I don't find the data terribly actionable. Again, beyond raising the consciousness of a provider to attend to this more closely during an individual patient visit, I don't know how, or perhaps doing some outreach for those folks that have not had a blood pressure checked or are uncontrolled. You know, I don't find this quite as helpful in terms of some report I would run on a regular basis. So again, the point there is, you know, what kind of data would you find actionable? What kind of data is an area that you'd like to improve in, that you could gather some data to help, you know, guide those decisions, and it's actually going to be something you're going to care to look at on a regular basis and see some progress. So the foot exam in the diabetic patient is what's represented on this graph, and between 2005 and 2007 here you can see a pretty stale performance. The top line is the diabetic population, which is growing over this time period, but pretty much we're doing a handful of diabetes foot exams. Now, I can tell you in 2007, that's essentially when we adopted the registry. So what I'm showing with this example is the impact of the registry adoption on the documentation rate and the performance of guideline-driven care. So there's a certain level of awareness that once you realize that a foot exam, for instance, is something you want to document as part of your diabetes care, you're obviously going to be drawn more to focus on that. And just the fact that you have a registry in place, I think is going to improve your numbers because there's a focus on it. So initially what we were doing was capturing data through direct entry into the registry at the point of care. Sort of, remember those three options. This is sort of stage one. And it requires a little bit more work, but you can see we did move this measure. We got our foot exams, at least the ones that were documented, increasing, again, because we cared to measure it now. And that arrow there shows basically the point at which we decided to adopt a registry. But we were doing that double data entry. So direct data entry at the point of care evolved into data recording in a standardized format in the physical exam within the EHR. And then we queried and uploaded to a registry at a later time. So we moved from sort of that double data entry to let's just report it once, but then for our reporting in the registry, we're going to upload it in a batch later. And you can see the impact of that was quite a bit more significant. Now that you know, we cared about the measure, it was something we were checking, but we had an easy way of documenting it. The apparent compliance with this measure really rose. So I'm going to look at now diabetic nephropathy screening, and this would be an example of maintaining your data systems. So again, those early to sort of collecting clinical data are going to find there's a lot of work before you even get actionable numbers that goes into cleaning your data, making sure you're collecting all of it. This was the report that we had as of August 2010 on our assessment for nephropathy. So this would be, for instance, that they'd had a urine microalbumin performed in the last year. So again, we're dealing with a population of about 45 diabetics, and you know, under 20 of them, and in apparent dropping numbers, are getting nephropathy screening. So we looked at that graph and we thought, well, something just doesn't seem right. I really, you know, for a small practice, my wife and I said, no, I think we're doing more screenings than that. So it prompted some troubleshooting of the queries that we were using to interface our data collection in the EHR with the registry, which again is web-based. And we indeed identified a problem with our system's data collection, and we corrected it. So it basically became a technicality here. But once we corrected the technicality, you can see the actual numbers in blue. We're doing quite a bit better than the sort of before the intervention in pink there. So again, you'll find sort of vast improvement simply from discovering glitches in the system. I think is the point of this slide. Flu shots was sort of an evolution of outreach here in terms of the flu shot. So we synchronized our EMR immunization records with our registry. We basically want to improve the accuracy of our flu shot documentation because this is part of our guideline-based diabetes care. And so in 2008, this became basically an internal process improvement method to better synchronize the data. And this is what we saw. This hump basically represents the fall of 2008, where we seemingly improved the documentation just by integrating our EHR data with our registry data. So 2009 rolled around, and we're a patient-centered medical home by this point, and we're trying to be a better medical neighbor. And so we thought, well, perhaps we're doing better than we think we are because patients are getting their flu shots at Walmart or Safeway. And so we contacted our local pharmacies and we asked them to report to us on our patients that received flu shots. And they had systems in place to do this already. We just confirmed how they were going to send us the data and make sure that they had all of our contact information correct to do that. And then what we did was, as they sent us information, for instance, a roster of patients that had gotten flu shots at their pharmacy, we would record that into our system, into our EHR, and then that was already being automatically synced with the registry. So again, this is instead of an internal process, now we've sort of turned outward and we're doing some external process improvement. And this is the impact. Again, every year, the way it's reported as a flu shot in the last year, you sort of see this hump and then it sort of normalizes. So actually the kind of baseline that you see here would be the effective rate. So if you move from before the arrow baseline there to after the arrow, I guess we learned that this really didn't have a big impact. So it wasn't that our patients were all going out to Safeway and Walmart to get their flu shots. Well, so what was it? So 2010 rolled around, and we thought, well, maybe we need to go right to the patients. We've got our systems in place. We know we're capturing all the stuff in the community. Let's just go after the patients this time. So we used this was a product actually I think provided through Sanofi of all people, who their interest in selling more flu shots was that they offered us use of something called Call-em-all. And Call-em-all basically records a message and then does a robo-dial sort of to a list that you give them. So this was the message, the text that we used for this 2010 outreach, basically saying that we had a flu shot coming up, and if you have diabetes or asthma, come on in. Don't bother RSVPing, just come by and we'll get you your flu shot. So we sent this out to our diabetes and asthma population. You can see the little graph you get back from Call-em-all tells you that 57% of the calls were answered by a live person, 43% went to voicemail. Okay, so here's the impact of that measure by, we got a nice little hump, but again, the baseline, it moved a few patients, but at this point we had contacted all the people that we thought should get flu shots, and we're still getting about only half of them actually doing it. So, it's interesting, we came to think in time, we can make some marginal improvements, but at some point you get to just, some patients believe in flu shots and some don't, and I think that's more and more what we found is that this upper half is people that just don't believe in flu shots, and no matter how much we do, we don't seem to be able to change that. So this slide I think is a little bit more of a summary slide here in terms of how do you get to actionable data, and don't expect it to happen overnight. I mean, first it's important to pick the target measures that you're going to care about, and then establish your system around collecting the data for that measure. And you want to focus both on some process measures to sort of decide how well you're doing on this in terms of just collecting the data, as well as the clinical outcomes in terms of the actual health of the population or the issue you're looking at. So start collecting data on both, but kind of ignore the outcome data at first. First, look at that process data, and make sure that if there's internal or external process improvements that you can make, first focus on that. You don't want to come at patients with sort of bad data. You want to make sure that you've got all of your systems in place. But work until you can trust that the process data is good, and then you can start having the actionable outcomes that allow you to actually start doing some of the fun work of really moving the numbers in terms of clinical impact. So plan some changes, go ahead and implement them, study the results. Many of you are familiar with PDSA cycles. You plan, do, study, act is sort of this continuous quality improvement. And so perform the outreach perhaps that you need to fill gaps in care. And then it becomes just keep measuring and keep improving. Starting a quality improvement, we've been medical home coming up on 3 years here now, and sort of watching several years of data, you see things start to slump after a while. You make great strides, improvement in one area, and then it sort of tails off when you're not focused on it so much anymore. And so there's never going to be perfection in this world of quality improvement in medicine. You're constantly going to be looking back at what can we improve, but having a certain sense of realism that perfection is not what we're going for. We just want to do a little better or the best that we can. So these next few slides will show you kind of the progression from early on when you're dealing primarily with getting process figured out. As we started in 2007, October, remember that was about when we started using a registry, we had 39 diabetics in our practice. We had an A1C on about 24 of them, so 61% documentation. That would be sort of the process measure. In our registry, it counted it as over 9 if it was not even measured. So this sort of number looks artificially high, as 43% of our diabetics are uncontrolled. So at this point, you look at this and you say, well, I can't be judged on that because we just don't even know what those are. They could be just fine. So this is where you're sort of focusing on improving your internal processes. We're kind of getting there. At this point, we've got the documentation rate up to 78% now. We still look like about a quarter of our patients appear uncontrolled, and about half of our population is where we want them to be, under 7 in this case. So we'll give it another year and a half, and we've last gotten our process measure figured out. We've been able to do some outreach perhaps to get that documentation rate now up to 95%. So now we can start looking at the outcome numbers and have a sense, okay, so there's actually 4 patients that are really out of control. We've got a quarter of our patients controlled, and interestingly, still, I remember it was about 50% before that were in sort of the in-between zone. It's only 37%. So interestingly, as we improved our documentation rate, the number of patients that were controlled stayed about half. So I find that interesting, but your sampling initially may or may not be reflective of the actual performance on the measure. And this graph will show you, again, the total population in red up top there, and then the documentation rate you can see pretty low if we started out. By 2007 here, we're starting to use a registry, and what we see there is that we start to drop the patients attributed as uncontrolled. This sort of tan line starts to go down as we increase our documentation rate. But again, interestingly, the number of controlled patients stays kind of right about 50% in the middle. So anyway, I'm not saying this would be the case for everyone, but it was interesting in our practice that as we improved our process measure, some of the outcomes changed significantly and some of them didn't. Okay, so maybe one sort of take-home point here, and I think we've only got a couple minutes left, is that if you have not captured enough of the relevant data to have confidence in what the registry tells you, then you'll be unlikely to rely on it, and eventually you will stop using it. So make sure it works. Make sure you put the effort in to get the workflow to support the registry, again, to help you do your work in the office more efficiently so that you see some value in using it, but then also actually getting to the point where you have that meaningful data that allows you to make actionable decisions. So I'm going to end there, end of the talk, and again, be happy to take any questions at this point.
Quick practical question. Do you recall how much money you spent on this separate registry on top of your EHR?
It's sweat and tears and time, but very little money. This was a sort of a pet project of my own, the Access database that I showed you there.
You wrote it yourself?
I built it myself, and it was at the time our EHR didn't really have very good document management functionality. It since has built some out, but we've continued to use that system. And I know, as I've looked at other EHR products here more recently, a lot of them have done some improvement in that area of document management. But again, it's an important area of EHR functionality to look at because I think it's often overlooked. You've sort of demoed the documentation of the clinical encounter, but not really how your front office staff is going to route things to the back office staff and not overwhelm them, and sort of how do you prioritize things. But yeah, so the example I showed there was something that we built in-house.
Thank you.
Are there any other questions? That was a good question. Okay, great. If you think of anything after the webinar, just feel free to send me an email and I'll forward it on to Dr. Sharp. He will be joining us at the Learning Collaborative on January 13th. You'll all be there, and he'll be facilitating a couple of the breakout sessions, one talking about looking at small practices, and then he'll be facilitating a couple others. So you'll all get to meet him in person. And with that, we'll go ahead and close out, and I'll send out the presentation for you. Hopefully we'll have this also uploaded to our website by the end of next week.
Thank you.
Another question? Yes.
No, I was just saying thank you.
Oh, good. Okay, thank you.
Thank you. Look forward to meeting you all.
Take care.
Bye-bye.
Bye.
Bye.
I didn't know if they were responding to me or not.
And Julie.
Funny.
So when?
I got to give Diane the dates. Do you have the dates in there? We can just give it to her. It's all good, Webinars. Those are the webinars. Okay. Okay, Beth, you know what I thought? I thought I would give you Brooke's card. And if you guys want